Hello, everyone. I'm going to present to you about HPV vaccination from a global perspective. My name is Bloem. I work at the Department of Immunization in the World Health Organization in Geneva, and I'm the HPV vaccine impact lead. The structure of my presentation is that I'll talk about the global status of introductions, and then we'll look at the performance of HPV programs globally, and then we'll look at what's new on vaccines in the products and optimized schedules. And finally, we look at the challenge of improving and sustaining coverage. In 2020, WHO launched a global strategy to eliminate cervical cancer. And to do that, there are 3 pillars, and vaccination is one of the key pillars. Reaching 90% is the target, and all countries need to introduce. And this can prevent more than 45 million deaths over the next century in low and middle income countries alone, where the majority of the burden is. Currently, there are 120 countries that have introduced HPV vaccines. So that is good news, 60% of them. But the countries that haven't introduced actually represent more than 59% of cervical cancer cases, and they're the majority of the population. And also, the pace of new introductions is unfortunately going down. And you can see in the last couple of years, when COVID hit, this also went down further. So we really need to introduce much faster in countries that will be the most low-income countries. And you can see that here. On the right side, you can see the distribution by income level. And this clearly shows that the low-income countries have the lowest rate of introduction. And as we go up towards the high-income countries, you can see this growing. You can also see on the other side that there is disparities between regions, and that the Americas regions, where most of you who are listening today will belong to, have reached very high levels of introduction. So that's really good. So how are countries doing with their HPV programs? The good news is that high coverage, 80 or 90%, can be reached both in high-income countries, and in lower and middle-income countries. But the less good news is that on the tail end of both of these graphs, you can see so many countries that have very low coverages. In high-income countries, the average coverage is better. You can see it's around 70% and even went up from last year. In the lower middle-income countries, you can see the average going down, and the average HPV-1, so first dose coverage, is below 50%, which is really low. We have another measure, which is the global vaccine coverage, and we do this for all vaccines. And when we calculate towards the global cohort of girls who receives HPV vaccines, we can see this stands only at 15% for the first dose among girls and 12% for boys. And you can also see that this has gone down by nearly 25% in the last 2 years. So COVID has had a strong impact. But again, the bigger point is we are still at very low levels, and many girls in the world do not yet get this life-saving vaccine. Here you can see a bit better how COVID has affected the programs in the various regions. The overall picture is lower income regions, or regions with many low-income countries, have been hardest hit. This is the case for Africa, and we saw this later in Sierra and Wipro as well. Also, the Americas has been hit very strongly, and you can see that performance has gone down. Only in Europe, which are mostly high-income countries, you can see it has remained stable. To look a bit at the region of the Americas, this is again a population-based measure, so across all the girls in the region. You can see it reached 70% with the first dose coverage in 2017. And so the decline that we're witnessing in the last couple of years already started earlier, pre-COVID. But COVID clearly exacerbated the situation, and there was an overall decline of 27% in this region. So a lot of work to be done in the Americas region. If we look at the situation by country, some countries have gone slightly positive and improved the situation, such as Brazil. And also the USA has shown gradual increase, whereas many others had a worsened situation. Mexico stands out because it faced a supply shortage, and the vaccine that they were using was no longer delivered. So this is an issue we'll see somewhat later as well, and that has hampered various countries in the world, but it has also led to delays in introduction globally. And here you can see our current global market study. And this in the green and the red shows whether we have insufficient supply in the short or long term or good supply. We now see many more green boxes, particularly in the midterm and the long term, but also if we start using a one-dose routine vaccination, we can see green boxes in the short term. This means that the supply shortages that we have seen since 2018 are now diminishing, and that we will be getting into better situation and that the market for HPV vaccine is improving. Here you can see why. We've had Merck and GSK who have been increasing and ramping up their production, and most of that is coming online in the end of this year and next year. So the situation will become better. But also we've seen new vaccines from in China, Innovax and Volvax, come to market. They're available at the local level in China, but now also internationally. And we'll soon have an Indian product from the Serum Institute, and that will both help to create healthier markets. The other news comes from the scientific end. You may remember that Kramer found in 2011 that women who accidentally received one dose had a remarkable stable immune response, and that this was actually linked to quite similar levels of protection. This was from a very small study. So other groups took this issue up, and the opportunity was raised in India, where a large trial was ongoing, supported by the IARC, the International Agency for Research on Cancer, that was interrupted in 2010. And the interrupted groups included women that had only received one dose. And you can see here that the number of one-dose women is quite considerable. They were not randomized to this group, but they are larger groups. And when 10 years later, last year, we looked at the efficacy against persistent infection, a precursor for cervical lesions and cervical cancer, the protection between the three groups was the same levels. So no difference between 1, 2, and 3 doses. So this is very intriguing information that needed to be confirmed by randomized trials that were specifically made to look at one dose. And this information we now received from the trial in Kenya. The Kenshi trial had 3 arms, a 9-valent, a 2-valent, and a control group. And what we saw after 18 months in these groups was that the protection offered by one dose was 97.5%. Similar efficacy as was seen in the original trials when HPV vaccines were licensed. So it's this body of evidence that has convinced SAGE that we now know that one dose has a high level of protection, that this protection has a duration of at least 10 years, and given the trajectory, looks like being at least 20 years. And therefore, they recommend to change the recommendations for HPV vaccine schedule. And here you can see what the summary of the recommendations look like. These will be confirmed by the position paper end of this year, but you can see that a 2-dose schedule is now recommended across all age group as of 9 years of age, that a 1-dose is an option that can be used for the 9 to 20 years old, and there are also changes for the immunocompromised, although we think they should ideally continue to receive 3 doses as more information on this group is needed. And this information, while most of it has been gathered on girls, SAGE indicated that there is all likelihood that it will work the same as in boys, so it can be used in both sexes. Although more information is needed, more research is needed on the 1 dose in boys as well as in older populations, and this needs to be followed up. So these recommendations will have an impact and will create more flexibility for countries to improve their coverage. Because in the long run, the impact of HPV vaccines is, of course, a sum of individual protection and then particularly the coverage through population protection. So how do we get there? Improving population protection. How do we improve and sustain coverage? Well, first, doing good introductions. Laos was a country that showed how this could be done. They were able to reach 76% coverage in the first year of their introduction, in spite of the COVID outbreak. They moved from schools where they were going to vaccinate to facility-based. They did a lot of communication, particularly girl-centered communication, which is new to the country, and were successful in any case in the first year. So this is important because what we've seen is that what happens in the first year has an influence in many years to come. We also analyzed the influence of the choice of the vaccine delivery strategy. And we do see that overall there is higher coverage when you choose schools compared to facilities. And the mixed group here are countries that also use the schools quite a lot. We also see, however, that of course schools can be more vulnerable when external events happen, such as the COVID pandemic, and school closures happen. So there's a trade-off there, and the facility-based programs were more resilient. So some lessons learned from countries. This is a country that performed very well. Malaysia, one of the first countries to introduce, which had a predominantly Muslim population. They therefore worked strongly with religious leaders. They made sure that the vaccine got an halal support, that schools and parents were well informed, and they integrated the vaccine in the school health program. So you can see they were able to reach high coverage and have been able to do so since. There are also countries where the low coverage is sticky. France is an example. They reached low coverage at the beginning. There were many controversies in the country, and there are many voices talking about hesitancy in France, and that has been hampering the vaccination. But it's still strange that why we see such low levels with HPV, whereas we don't see it with other vaccines. So in the same country here, you can see what the second dose of measles has done. And it has reached now 86% coverage. Too low for measles, so the country is at risk of an epidemic, of a measles outbreak. But it's still nearly twice as high as HPV coverage. So we should be able to do better. And what we propose is that low-performing countries should really all do an introduction, in a post-introduction evaluation for early course correction. They should extend their communication strategies beyond the first years and really potentially work the first decade to establish the norm of HPV vaccination. And we need to better understand what are the behavioral and social drivers of demand. And we're developing now a tool to help countries do that. Finally, a country that dealt with crisis quite successfully. In Denmark, the program that was doing very well was affected by a crisis based on POTS, a syndrome, a very rare syndrome that was suspected to be linked with HPV, and it turned out to be not the case. The coverage, as you can see, dropped and nearly plummeted to 16% in 2016. But then a new campaign kicked in. They did their crisis communication, worked with parents, girls, and they built the trust in the health professionals that this vaccine is safe. But more than that, they went back to their partnerships with the OBGYN, the oncologists, the cancer organizations who had been pushing for the introduction of this vaccine, but then didn't really collaborate with the program and were not asked for their support. And now they are, and it worked very well. And so this is really a lesson learned for all countries, that they should continue working with these important groups to build the demand for this vaccine among the various target populations. If you're interested in looking some of the data sources that I used, and for example, look at the performance of your country, you can find it here. And with that, I'd really like to thank you for your attention. And as we all know, the ball is now in your court. We all hope that coverages in your country and other countries surrounding you particularly in the Americas, will improve in the coming years. Thank you.